those intersections of technology, law, policy, and healthcare. We're very fortunate that tonight this exceptional panel brings each of these perspectives. It'll help us understand what we can learn from the Ebola crisis, and I hope you'll join me in looking forward to how this conversation will inevitably spark new ways to make a difference. Thank you.
Wonderful, thanks, Lynn. All right, I'm going to invite my fellow panelists to come up and join me on stage. Take your seats in no particular order. And let's dive in. Don't forget your note cards. Start writing. So first thing that we'll do, other than get everyone seated and situated and oriented to their microphones, is a quick round of introductions. We have a panel that has a very wide variety of perspectives and lenses on the Ebola crisis. So what I want to start with is very quick, a couple minute introductions from each of you on who you are and your lens into the crisis, right? Whether it's on the ground or thinking about big systems or policy change or volunteerism or what have you. So Warren, why don't we start with you?
Thank you, Donna. So I'm Ron Klain. I'm the White House Ebola Response Coordinator. It's my principal lens into this crisis. I was sitting at my desk at Revolution, the local venture capital firm, in mid-October when a call came and asked if I was willing to leave my job and come work at the White House to try to fight Ebola for 4 months. And that's what I've been doing. And my perspective on this is I came to this as someone who's been involved in the technology field and interested in the role that technology can play in solving social problems. And over the past 4 months, it's been fascinating to me to see all the different ways that old technologies, new technologies, and a whole variety of everything in between has played such a huge role and had such a huge impact in our efforts to fight Ebola in West Africa and here at home. But I will say this, I do want to end my little introductory comment with saying that it has also been a reminder that in the end, the thing that's made a difference in West Africa is people. Not any technology at all, but the willingness of people to get on planes and go there and fight this disease on the front lines, the willingness of people to put themselves at risk to take care of other people and treat other people. And technology has been a force multiplier in that. It's been a key tool that those fighters have used, but we should never forget that what fights an epidemic and what powers a response to an epidemic at the end of the day is human beings who are willing to go help one another. And that's what I've seen over the past 4 months.
Good evening, everyone. Thank you to all the organizers and sponsors of this event, and thanks to all of you. It's great to see such a packed room. So my role, I'm originally from Liberia, and so I keep saying I have multifaceted roles in this Ebola crisis. The first is quite personal, with family, friends impacted by the crisis from back in July. Getting calls saying, this is crazy, it's happening, it's escalating, and people are scared. To family members in the healthcare sector in Liberia, very closely connected, riding in ambulances with fellow medical professionals who had already contracted the disease. And so I was afraid for my family members, and that was probably the first engagement with this. But as a member of the diaspora, that worry quickly turned to action. And I feel like I've never been more proud of our diaspora community. All of the countries, not just Liberia, Sierra Leone, and Guinea that were most dramatically impacted, but also Nigeria, Ghana, the diasporas kicked into gear. You had people volunteering their time, volunteering their services, giving of their talent. So in a number of ways, I got involved in diaspora efforts. Many were sending personal protective gear before most people even knew what that meant. Organizing on weekends and in their church halls, and some had access when Walter Reed closed. It was giving away medicines, and they stored them up in storage areas and had gloves and all kinds of gear available. So the diaspora was another way in which I connected and engaged. But I started out my career at Oxfam in the development world and went to Interaction, the Network of Development Organization. And for 11 years was with the Institute for Policy Studies, a progressive think tank here in DC. And about 9 months ago, left the think tank world to join ThoughtWorks, which is a global technology firm committed to economic and social justice. So here I was, suddenly, at a tech firm with 3,000 brilliant software engineers who had experience in global health practices, who had also gotten involved in the typhoon in the Philippines and emergency responses, and they were like, what can we do? So we got connected, we got involved, we just jumped right in. So we got involved in a number of tools, which hopefully we'll talk about further. But I guess I just wanted to say that the roles are many and multifaceted, and I think for many in this audience, especially the diaspora that are in this audience, I just want to thank them as well as those on the ground. You had government officials, you had non-governmental organizations, as well as the embassies are really kicking into gear and getting involved. And I just applaud everyone for all of the courageous acts that you all have taken.
Good evening. My name is Dan Busick. I'm an infectious disease physician, public health physician, and I teach at Georgetown. And I first noticed the report about Ebola at March 23rd on the World Health Organization website, where it was mentioned that from the very beginning, it was recognized that there were some patients, 20 with 6 fatalities in Conakry, the capital of Guinea. And by early April, there were patients with Ebola in Monrovia, the capital of Liberia, that officially been reported to the World Health Organization. This is something that's never been known to happen before, and that is Ebola in capital cities, where there are the government, but also international airports. So it really caught my attention. I put part of the exams I was teaching at Georgetown last April to the students, these test questions, what's new about Ebola, it's never happened before. But really what I want to do is be able to go over to West Africa, to the outbreak sites, which is something I've done over the years, pretty much every year since 2003 with SARS and MERS and bird flu and pandemic flu and Nipah virus. And so finally, in August 10th, I was able to go to Freetown, Sierra Leone for 3 weeks, particularly work with the Ministry of Health and help train nurses and doctors on Ebola, personal protective equipment. And then I was very pleased to be able to go to Doctors Without Borders from October 3rd to November 14th in Monrovia, when Monrovia, Liberia was the epicenter. Before now, Freetown became the epicenter in December. So it's really an honor and a privilege to be here to talk with you briefly and participate in this discussion.
So my name's Mark Smith. Unlike Dan, and I hope he's going to get, I know he's going to get a chance to describe some of his personal experiences in caring for Ebola patients under limited conditions. I had no direct involvement in the Ebola response. So why am I here? I'm an emergency physician, and I've been an emergency physician in Washington, D.C. for 30 plus years. I ran emergency services at George Washington for 12 years and then Washington Hospital Center for about 15. I've had a long interest in emergency preparedness, and back in 2000 we actually developed Project ER1, which is trying to figure out what should be the design features of an emergency service center that could manage the medical consequences of mass casualties, emerging illness, and chemical and radiation contamination. How do we manage capacity, how do we manage capability, and how do we manage protection? I am currently the director of the MedStar Institute for Innovation at MedStar Health and the chief innovation officer of MedStar Health, and I'm most interested in trying to look at things from a system perspective, see what it is that we can learn from single incidents and change systems for all the incidents. So take a single, don't do a one-off solution, but try to find what's the more general problem and issue that we can deal with, that we can help the next problem that comes on in the future.
Jack?
Hello, my name is Jack Dangeman. I'm a geographer, and I own a software company that makes mapping software or geographic information systems. When a couple of years ago I became interested in epidemiology and worked with Bill Gates on trying to squeeze out the polio virus in Nigeria. Through that I met some good people at WHO, Bruce Hayward and others. And so when this epidemic really started to catch on, he called me and asked if we would help him. So we sent a whole team of people to Geneva and then later to West Africa to stand up mapping of the epidemic. That meant really capturing observational data on devices, transactionally updating it to the cloud, and then in Geneva having these online reports that showed the risk and trajectories and statistical trajectories of the spread of the disease. And, my lens on this is that I see everything spatially and computationally. So in the case of polio, Bill Gates credits mapping as one of the things that helped squeeze it out. There's a lot of things that helped, but this was a big one. In the case of Ebola, seeing things spatially gave a kind of frame for people that wanted to develop geographic quarantine programs. So I just say geography matters, that's my bias, and I'm sticking with that story.
That's your story, you're sticking to it. All right, so as you can see, we have an amazing panel and very different perspectives. So let's dive in. And the way that I want to organize the conversation is let's start where we are today. Let's then rewind and talk about where we've been, what we've observed, how technology has or hasn't been deployed, where those opportunities are. And then let's project what does that look like in the future. How do we learn and improve so that in the future we're doing a better job and we're thinking about the epidemics that will come inevitably behind this. So why don't we start with today. President Obama gave a speech today on the Ebola crisis. Would love to hear from you sort of the top line takeaways from that, and what does that mean in terms of the response to the Ebola crisis?
Well, today the president announced that we're going to bring 2,900 of our 3,000 troops in West Africa home by April 30th. It reflects the progress we've made both in fighting the disease and in taking on the tasks that those troops undertook, which was largely to train healthcare workers and to build Ebola treatment units in Liberia. He also made the point, though, that we're nowhere close to the end on fighting this epidemic. We sent our troops in because at the time we did, a lot of civilians were willing to go to Liberia to fight the disease. They felt it was unsafe. We had NGOs actually pulling out of the region. So American soldiers, service people went over there and catalyzed the response. Since then, we now have over 10,000 US-backed civilian responders in the region. It doesn't include probably an equal number of responders from other countries. It's one of the largest assemblages of healthcare workers and epidemiologists probably ever in the history of the world. And so the point the president made today was that even as our troops come home, our response continues. We're actually sending even more civilians over there. I think if you look at where we are in the disease, we made tremendous progress in Liberia. We've gone from hundreds of cases a week to last week 3 cases, the week before that 5 cases. Tremendous progress over there. In Sierra Leone, again, some significant progress, but the case incidence level remains very, very high. Gone from a peak of about 600 a week down to about 70 a week. It's a big change. But it's worth keeping in mind, 70 Ebola cases a week would have been the worst epidemic in the history of the world until now. So even at the reduced level, it's still horrific. In Guinea, we have tremendous problems with the response. The number of cases is somewhat lower, but it keeps going up and down. It's not really following an established pattern. It doesn't show that we've broken the curve at all. And that we can talk about why that is, but it's certainly problematic. So I think that's where we are today, which is a lot of progress in Liberia, progress, but still too many cases in Sierra Leone, and mixed results in Guinea. The last thing I'll say is, as the president said today, there's only one goal for fighting Ebola, that's getting to 0. It's worth remembering that just 7 or 8 months ago, in the late spring of 2014, it looked like the epidemic was under control. There were only a handful of cases left, and we believe now it was just merely 1 case in Guinea that wasn't controlled that reignited this entire epidemic. So like a forest fire, even one ember can flame up and burn down an entire forest. This is not over till we're at zero, and the Obama administration is not going to stop fighting it until we get to zero.
So I envision that there aren't very many people in the audience who have spent time on the ground. Raise your hand if you have in the Ebola crisis. So I think helpful context, Dan, maybe if you could tell us, from having been on the ground and what that is like, paint a word picture for us of what it was like to be on the ground, both the situation, but how you actually managed the gear, the information collection, the triaging, the reporting that goes along with that. Give us a view.
Do my best in a very short period of time. In Sierra Leone in August, I worked at a testing, inpatient testing facility, and then it was a treatment facility for 6 weeks in Monrovia. The second was with Doctors Without Borders. And in both places, there's a standard of care, standard of medicine that I've never seen before, let alone practiced before. It was an extremely sobering experience in both places. That said, you have to start with whatever the situation is and then do everything you can to make it better. By working with your colleagues from Sierra Leone, from Liberia, in Sierra Leone, colleagues from Spain and the UK, and then Doctors Without Borders are people from everywhere, from Iran, from Pakistan, from Cuba, from Brazil, from Europe, from Australia, etc. But mostly it's working with Liberian and Sierra Leonean colleagues, healthcare workers. Not very many doctors, because there aren't very many doctors. And a lot of the doctors and nurses who've bravely gone to take care of patients have gotten infected. Over 830 have gotten infected. West African healthcare workers, and all 500 have died, but they continue working. So basically, we didn't have access to any kind of laboratory tests except for the virus itself. So no potassium, which becomes very, very low when you're vomiting and have diarrhea. It can be life-threatening. Become very, very dehydrated. We didn't have access to any intravenous fluids, either in Sierra Leone or in Liberia for the 6 weeks. This Ebola epidemic is primarily one of intestinal infection, vomiting and diarrhea. It's not bleeding. It's not hemorrhage bleeding. There may be some bleeding, some red eyes, but it's mostly vomiting and diarrhea. And then if the tents where the patients are, the hospitals are tents with a mattress on the floor. That's what the Dutch Doctors Hospital was in Monrovia. You have to wear, healthcare workers have to be protected. So I like to call Ebola personal protective equipment, because it's not just personal protective equipment like any other PPE, personal protective equipment. It's very specific what it is. It's very specific about the process of safely taking off the equipment. When you put it on, you have to do it right. And really, you should have somebody whose full-time job it is to help you do it, make sure you're dressed properly. But there's no virus when you're putting it on, it's when you're taking it off. That's when if you don't do it correctly, again, with the help of someone full-time, then you can get infected yourself. Sierra Leone, we didn't have anybody in August helping us. Doctors Without Borders, we did. So that was very important. We were only allowed to stay in for 45 minutes in the morning and then 45 minutes in the afternoon, according to the rules of Doctors Without Borders. Because you sweat so profusely, your boots fill up with your own sweat. It's like you're walking in a pond. Your mask can fill up with sweat, so you help the patient to sit up, so you can help them to drink the oral rehydration solution that has the potassium that can save their life, the sodium and the sugar and the water. And this is it. This is the only way to get rehydrated and to avoid dying of what we call shock, advanced dehydration. When you do that, you help the patient to sit up, you help them to drink from the side, because if they vomit, then they don't vomit inadvertently, of course, right on you. So you're doing it from the side. But then if you too quickly stand up or move your head back, then your own sweat that's in your mask can go up into your nose. So you learn to adapt to all these things. But most of all, for me as a physician, it was very, very difficult knowing that, for example, when I first got to Monrovia on October 3rd, I had part of a large team of Liberian nurses, physician assistants, nurses' aides. We had 46 patients, and 45 minutes in the morning, 45 minutes in the afternoon. And you always wish that you could do more. So you find ways to do more and to be more effective and to spend more time with the patients that need you the most. And then the final thing I want to say is that I think the most important improvisation, innovation that we did sounds so simple, but it was simple, but it was very effective. And that was to ask the patients who are starting to recover, what I call the pre-survivors, who are able to take care of themselves, no more diarrhea, vomiting, they can eat and drink, walk and talk. They asked me for extra batteries for the radios. I said, wonderful. And they're complaining about the taste of the food. They said, wonderful, you're going to survive. But now you're a pre-survivor, you still have virus in your blood, you can't go home, so please go back into the ceiling hot tents and help the patients there to drink and eat 24 hours a day because you're there all the time. We can only come in for short periods of time and leave because of the protective equipment. And that made a huge difference. We had 74 patients with Ebola who survived between October the 8th and November the 13th at the hospital in Monrovia, which was about twice as many who died, but still far, far too many who died.
So as a point of transition, when we begin to talk about the role of technology, I would love if you could tell the story that you told me earlier about record keeping. When you are in the tent for that 45 minutes and you're seeing, 1 minute per patient, but yet you've got to record what you did with those patients in that 1 minute, but not take anything out of the tent.
Very briefly, anything that goes into the hot zone with the tents, and there were 10 tents, and our team was responsible for 4 of the tents. Anything that goes in can't come out because there are virus on it. And so I can't remember all the information about 46 patients, maybe 6, but not 46, so we write pieces of paper. It's very low tech, or very low tech. And you write notes as you're going along. You do everything in one motion. You ask, are you having running stomach, which means diarrhea? Are you having vomiting? And I'm not really, the answer is yes, because you can see the fluid everywhere. Then you help the patient sit up, you help them with the drink, and you give what I started to rule, it has to be directly observed therapy. In other words, medicines to stop the vomiting and diarrhea, medicines for malaria, medicines for fever, other antibiotics for typhoid, whatever else the patient might have. So you're doing all this in 1 minute. It's not good. It's not good. And then you take notes, and you go see the next patient, and you wash your hands real quickly in between. So now you've got 46 patients and notes on 46 patients, and you have to get out, and you're sweating and sweating and sweating. You can't breathe. You're gasping. Your mask is going out like this, and it's collapsing, and you're wondering, am I going to make it? Am I going to make it? And you always make it. But now you have to transmit the information on the 46 patients to the main nursing area. But how do you do that? Well, there's scanners. Dr. Zuppers had 2 scanners for 8 tents, but the scanners didn't work. And so this is the end. You stayed already now like an hour and a half. You're only supposed to stay 45 minutes, and then say, Lucy, you're breaking the rules. We're going to put you on the plane back to Europe if you do this anymore. I said, I'm going to say I won't do it anymore. So you do it more. But because you can have that kind of direct impact on the patient. So the scanners don't work, but sometimes they work, but sometimes they don't work. And it's so exasperating because you can't leave the information that you just gathered without getting it inside, because that's going to determine how you treat the patient when you come back in 3 or 4 hours from now. It's so maddening. So it's really low tech. But so this is what I did. I took the pieces of paper, which there might be 5 or 6, and I get as close as I could to the nursing desk window that's open, and the virus is not airborne, they're both not airborne. So you can get pretty close. And then one of the nurses, there was a European nurse, Gunnar, who basically took his cell phone camera and zoomed in, and I tore up the piece of paper, and he'd take a picture of the patient's name and what medicines we gave, and it was bad.
Feel free. Anybody else to jump in?
Well, I would love to jump in here because I can say that was then, and it's so changed now, and I'm really honored that we've been a part of that process. So the paper-based system that you heard described was pretty much in place in a lot of the Ebola treatment units. And we at ThoughtWorks, working together with a bunch of other allies, have now helped to build software solution to this. Using very sturdy tablets, Sony tablets, we've now been able to build a software that can go into the hot zone and be decontaminated and go out of the hot zone, right? So to move from a paper-based system to a tech tool that can help the doctors first know which patient is in the bed. Because remember, especially at the peak back in September, 100 patient beds were being filled by the end of the day, right? And the doctors didn't really have time to say, patient X with the red shirt is in this bed, to even be able to keep track of who's been treated with what and who was their family member to visit and all of these issues. Well, now there's a patient tracking system that's now based on this software tablet form, and information is being collected. So as of January, it's now in place in the Save the Children Ebola Treatment Center in Carytown, Sierra Leone. I don't know if that's the one you were in, and it's being expanded beyond that as well. So, you know, tech doesn't provide all the answers. You definitely need people at the forefront. But in the midst of these crises, there are tech tools that can help. And I think following on that's one of them. But I'd love to, if I can, talk about a couple others, because I do think there's some extraordinary lessons here. So, you know, as I said, I'm with ThoughtWorks, but ThoughtWorks, we also worked with an incredible alliance, a forum of primarily African and diaspora techies, who were at the forefront of building tech responses in their own context. So one of them, one of our allies was Evelyn Lewis, the founder of the SBTS group in Sierra Leone. SBTS group essentially created a call center. Now here in the US, you have a 911 system, right? 911 system didn't exist in Sierra Leone, or Liberia or Guinea actually. And now, thanks to the work of Sierra Leonean techies, you have a 711 system that was established in the midst of the Ebola crisis to take calls, to begin to figure out where the calls were coming from. We at ThoughtWorks helped to do a GIS mapping of where the calls were, so you could do sort of a real-time sense of where the calls were being generated to know what areas needed, whether it's burial teams or medical support and the rest. And you know, SBTS group, they didn't sort of sit on their laurels, but they're now working to set up kind of like 911, and then there's 311 here in the US. You all know the 311 system? Yeah. So they're setting up a non-emergency call center for healthcare workers. And we've been helping, and I say we, but we as ThoughtWorks, we as also Coders for Africa, Mensa CoLab, some of the folks that I know are in this audience who did hackathons here in DC, as well as hackathons we had in Brazil, in India, in Dallas, in New York, to help build these tools, right? So what we're now working on is this 311 system, a parallel call center for healthcare workers in Sierra Leone, and a ticketing system that will be established, as well as a GIS mapping. So we'll keep having the conversations with Esri on this panel. But these are the ways that techies, first on the ground, didn't stand by to say this disease is going to come and take us all, but they said we have skills and we're going to put those skills to use. And they worked with the diaspora as well as with other private sector firms like ThoughtWorks to make things happen in the midst of the crisis. And I think the emphasis is, you know, how to help build the public health infrastructure that not only responds to Ebola, but prevents future crises down the road. So there are many more, but just wanted to make sure in the midst of this conversation that we...
Those are actually excellent points, because I want to tease out two things that you just said. So first, I want to have Jack share with us a little bit about Esri's response and how the tools and the technology and the mapping have been deployed in Ebola. And then I want to turn to Mark and begin to talk about the bigger sort of let's not let this happen again. How do we change for the future based on what we've learned today? So Jack, why don't we start with you and talk a little bit about the technology that Esri has brought to the table. I know you've made a big investment and a commitment to this.
Well, I like geography, as obvious. And early in my career, I learned about computational geography, which is really organizing geographic phenomena into what you might think of as like layers, like plastic layers. So we would digitize these and then analyze the different relationships between these different layers and create understanding. That's the basic thrust here. In the Ebola case, we started off building a data model of different layers, and they were places where people lived. The demographic data, that was another set of layers. then where there were hospitals. And there was a big distinction between Ebola hospitals, as you know, and non-Ebola hospitals, because people were still getting sick and probably dying at the same rate in non-Ebola hospitals, so that designation was important. And then a data model that dealt with grave sites, outbreaks, places where infection was happening at countrywide and regional-wide levels. So we started by building the data model. It's basically abstracting geography into these layer sets, and then build these views for the data. You think of them as maps, but they were really dynamic view maps that would show the patterns of spread of the diseases or observations, and then do spatial statistics, trajectories to try to understand what was going on, the dynamics of the actual disease and its spread. The problems with it were horrible because we had very poor data. We didn't have good geocoding of where the observations were taking place, so we couldn't believe some of the statistics that were coming out of it. But it did give a general frame of reference for the people in Geneva to be able to send and dispatch people. That was the general notion. And just a general concept here is that geography is about understanding, or these GIS maps are about understanding. A good friend of mine, Richard Werman, who some of you guys know, he always says, understanding precedes action. So I'm just totally humbled by some of you guys' sharing, particularly you, Doctor, about going there. What we do in the GIS space is trying to develop the science for targeting different action, and some of them is just dispatching of people, but some of them are also geographic strategies, designing strategies like the quarantine systems, designing, so it's the linking of science to eye-brain design functions spatially. So that's had some real impacts and some real failures, actually. It's just total, as you know better than me, I only hear it through stories of my colleagues. It's just totally screwed up, not well organized at all. So I would like to say there's a really great story here, but there's also just a lot of shit messed up.
You can say that, you're in the startup community.
The emails were FUBAR, if you know that term, fucked up beyond belief. That chaos, we say it as a joke, but it was like any other disaster, I suppose. Some of you worked on different disasters and hurricanes and so on, but this one was one where there's an emotional dimension where you don't really know what the outcome's going to be. Because there's a trajectory that keeps saying it's going to exponentiate and there's going to be 100,000 people dead by the end of January. So everybody's just all in, but you don't really have understanding. So there's a human dimension there that got everybody quite fanatical in terms of trying to do something about it. You experienced it more for real on the ground. We were trying to abstract it at a distance with technologies. I don't know if that helps answer your question.
Well, if I just could, from our perspective at the White House, we divided the technology into 4 piles and went at it in 4 different piles. The first was data, as Jack was talking about. The biggest data problem we had was we weren't getting people tested for Ebola. So you can't map who has Ebola if you don't know who has Ebola. So we had a big testing challenge. But the work that Jack and others were doing to bring these data systems online was great and ultimately played a big part. We'll move from data to the 3 other areas we really focused on technology. The first was technologies that readily exist over here, not so much over there. The 2 technological heroes of the Ebola response were radio and cell phones. You may not think about those as technologies anymore. They were the technological heroes of the Ebola response. The reason we broke the back of Ebola was because people changed their behavior. They changed, we did polling as to why people were changing their behavior. It was because they were hearing messages on radio. But in October, 60% of the country of Guinea had no radio coverage. So we had to get radio signals so you get radio messages to people. You want to trace contacts, you want to find out if someone had contacts with Ebola, are they sick, are they not sick, so on and so forth. You had to get them on their cell phone. We had to expand cell phone coverage and use cell phones to track people down and communicate data. So radios and cell phones were the technological heroes of this thing. The third, so that existing technology, the next pile, were technologies almost ready, that we just tried to push over the finish line. The most important one was a point-of-care test, so that we didn't have to do labs and send them off to labs and so on and so forth. We've got those in the field now to being tested right now, very close to being ready. I think they will be a key tool before this epidemic is over. It's an example of a nearer technology. And then we spent a lot of time on the really breakthrough technologies that aren't quite there yet, but may well get there. Vaccines, which we went from not having one in phase 1 to having 2 right now, undergoing massive trials in Liberia, where 600 people have been vaccinated in Liberia in the past 2 days in a vaccine trial. And other kinds of technologies. AID ran a grand challenge on trying to come up with a new PPE suit that wouldn't have the problems that the doctor was talking about, and had some great innovative help from people like Under Armour and a wedding dressmaker and all kinds of other people got together and designed new PPE, which we're now putting into production, and hopefully will be in Africa in a few months. And so, those things, the brand new breakthrough technologies haven't yet played a part. I hope we can beat the epidemic, frankly, before they play a part, but they're a key part of fighting the next epidemic and innovating for that. But cell phones, radios.
That's an excellent tee up for Mark.
Yeah, number of comments I'd like to make. First, I'm so struck by, Ron, what you said, radios and cell phones. And what was lacking, if I can translate that, is a communications and an information infrastructure. And quite frankly, it's the same problem we have with healthcare in this country. I mean, you see it in hospitals, and there's been a kind of a explosion, and hopefully care will gradually get better. You would not believe healthcare tends to lag by 10, 15 years from other technology. So it's about building enduring infrastructure. The third kind of infrastructure, which I've heard 2 or 3 examples of already in the panel, is the learning infrastructure. Dan found it with his experience, that very simple, the strong help the weak, and that's something that emerged. And it's really remarkable how much we've learned. Look what happened in this country, and we also learned in this country. So I'll give you the perspective of the hospital and the emergency department response. It is in complete contrast in terms of the equipment that we have at our compared to what Dan was. But there are some general patterns. And we, first of all, notice how much we learned here. In the very beginning, we had a number of healthcare workers who contracted Ebola because they weren't practicing at a standard of, perhaps, say it that way, that we gradually came to accept as having to be necessary when we had any person who was under investigation, and had to treat all people under investigation as if they had had Ebola until proven otherwise. What was interesting was we learned very rapidly. We had our nurses, our nurse infection control head and our emergency department head went to Nebraska and learned from them. Our head of emergency management was in constant contact with Emory. So what you saw was this kind of tiered response of knowledge, and what that got translated into, interestingly, was the notion of a tiered response of care. Not every hospital has to be 100% able to manage the Ebola patient. And what was, I thought, really excellent was we evolved to, is it 30, 35, or 51? 51, thank you, Ron. 51 Ebola centers. We were one of them at the Washington Hospital Center, and it was a remarkable team effort. So that's the third thing. It's not just the doctors, not just the nurses, the respiratory therapists, it's the x-ray techs, it's everybody that you need. It's the environmental service workers, it's dietary, everyone's got to be part of this team and has to be trained. And you would think people would be reluctant. They're putting themselves at risk. I just have the highest I'm in awe of Dan's commitment and the others who actually went into the belly of the beast and put themselves at risk in those circumstances to help others. It's really the best of what it means to be a doctor and a healthcare worker. But our healthcare worker, our whole team, everyone, as long as they felt they were learning how to do it right and were practicing it. And the head of our emergency services, Bill Frona, he had his antenna up in July. And so we started training for this very early on. I talked about a team. We had 4 patients who were potentially under investigation, 2 that we really had to keep for 3 days. Nobody turned out to have Ebola. But how did we learn about those patients? Because of the screening at the airports. We got a phone call saying someone's coming in. We were totally prepared, and it was because it was not just the random person entering whom we had asking everybody, have you traveled to Africa? Do you have a fever? But we were notified beforehand because of a comprehensive communications response, an integrated one. And that was really, I was really amazed by that because that has not really happened before. You talk about the first responders of this country, the police, fire, and EMS. It's actually at least a quartet, police, fire, EMS, and hospitals, and you should add public health. And the first time that I saw all of those entities really, really working together. So I have a couple of more comments I'll make on maybe a little later on some of the other things we learned in terms of the facility design that should be optimum and the relationship between what we do in these incredibly extreme events and how it can be translated back into daily operations. But I've spoken long enough, and I'll let somebody else chat for a while.
I'm going to turn to some of the audience questions, and we've got some interesting ones queued up that fit in here. So we saw a lot of conversation online in social media about Ebola. So, what was the role of social media and social media tracking in detecting, mapping, and forecasting the spread of Ebola? Anybody want to comment on the social media angle here?
Well, I think in the region, social media played a critical role. I know for a fact, Liberia, Guinea, Sierra Leone, people were communicating on Facebook if you needed to reach anybody because people weren't going to offices, but you could reach them on Facebook or WhatsApp. So the various social media outlets were key in terms of communications and I think have remained critical. There were some organized efforts of groups. A group, for example, Citizens Alliance to Stop Ebola Liberia was really active in social media and linking up the work of civil society groups that had social media networks to engage them around Ebola. You also had musicians putting out videos. I mean, it was extraordinary, and throughout the region, really, in all the countries. But from Senegal straight through throughout the region, you had hip hop artists, you had musicians of all kinds bringing their talents. There were a number of compilation videos that went viral at the time because of social media that were putting out messages about Ebola. So I think, when we talk about an information and communications architecture, clearly, yes, radio was key, and social media, I think we should not underestimate. I wanted to go back to the issue of the phones. I think you had mentioned also the phones. It's extraordinary, the region, even the region where Ebola was kind of at its crisis point was where the 3 countries, Liberia, Sierra Leone, and Guinea meet. Even that kind of remote area, folks have cell phones. Now, it's not fancy smartphones, but it's feature phones, but folks have cell phones. And so the cell phone technology and especially SMS messaging, key part of this. And I guess one of the things I wanted, in terms of the tools developed, M-Hero was one of the tools developed that's now being used in Liberia, was developed, ThoughtWorks, InterHealth, a bunch of folks together with UNICEF developed this tool that would be a communications channel really for healthcare workers using SMS messaging. So the availability of phones and the penetration of cell phones throughout the region has been an enormous asset. And in spite of the fact that the web component, the internet access is still problematic, right? And we're constantly calling for greater attention to building the internet infrastructure in the region. But clearly, the use of SMS messaging and social media has been phenomenal.
So another question from the audience, probably this one might be for you. With so many agencies involved in this outbreak, there was very little data sharing across the orgs. How can we improve data sharing in the future? So anyone can feel free to comment.
I guess I don't agree with that. I think we had a tremendous amount of data sharing between CDC and USAID, and I don't think data sharing was really one of our problems. I think we also had a very talented team at the White House working on this. Dr. Holdren, head of Office of Science, Technology, and Policy, Mei Chu on his team was a real pioneer in this field who worked on this, and obviously Megan Smith, our relatively new CTO, who came in and played a key role. So I think, I don't really think data sharing was a problem. I want to go back to something that was said a second ago about how we delivered people to the right hospitals here in America, because I think it's actually an interesting study of the combination of technology and just systems, which is, early on in this thing, I was at a meeting and someone said, well, you're going to have all these people show up in emergency rooms, they're all going to have flu, and how are you going to know in America all these people with flu, how are you going to know they don't have Ebola? I said, well, we're going to ask people, were you in West Africa in the last 21 days? And if the answer was no, then your diagnosis is you don't have Ebola, okay? And the point is that led us to focus early on getting people when they came back to this country and using our best technology to identify people, no matter how they routed back to America, if their trip began in West Africa, finding them at the airport, matching them with a unique identifying number, giving them a cheap, free, old-fashioned burner cell phone, which we provided to every single person who came to this country from West Africa, so that we could call them every day and get their temperature. And we gave everyone a list of places to go if they had a fever. And the state public health authorities were matched up with people were matched up with hospitals. And that's how we were assured that if someone back from West Africa wound up with a fever, they wound up at the right hospital where the people were trained, where they had the equipment, and the protective gear to test for, and the lab equipment to test for Ebola, or near a lab to test for Ebola. And the point was, we didn't have to prepare every hospital in America for Ebola. We didn't have to train 700,000 healthcare workers. We had to prepare 50 hospitals with the equipment and the training to do that by capturing people appropriately and routing them appropriately. And that really made a big difference.
And just similar to not having to train every hospital, in a given hospital, you didn't have to train all the staff. You just have to make sure that there was a core staff available 24 hours a day who could handle this, and a physical site where you would bring these patients.
The comment about data sharing, I think the U.S. result, the sharing of U.S. data was remarkable. Even NGA, our National Geospatial Intelligence Organization, stood up a portal with maps for everybody to be able to use. Amazing. I mean, one of our spy, classified, deep agencies, along with everybody else. Internationally, the story was really different.